This lecture is the second half of our Gastroenterology section in our Step 2 High-Yield Review of Pediatrics. We're going to review volvulus and intussusception and how those relate in the presentation of bilious vomiting in a child, Meckel's diverticulum, and some fun facts to remember that, and then finish with diarrhea and gastroenteritis. Now, volvulus isn't a heavily tested topic on Step 2, but it can be very difficult to differentiate it from other diagnoses that present in very similar ways, including, but not exclusive to, duodenal atresia, pyloric stenosis, intussusception, and others. So it's important to know how this presents and now what differentiates it from those. So what is volvulus? It's simply a malrotation of the gut. And this happens in children who don't properly have their organs rotate during development. There's no need to go back and review all the different developmental abnormalities of the abdomen, but just know that if things don't end up where they're supposed to be in the rotation, you end up with a mesentery and a mesenteric artery system that's too short, and then the gut is free floating in the abdominal contents because it's not tied down. So that can lead it to twist on itself. And with a shortened mesentery and shortened arteries, you can get a lack of blood flow to the gut itself, which can cause ischemia, and you get obstruction because it's twisted, so there's no passage of stool contents and air. So these kids present almost all the time, 90%, within the first 12 months of their life. So this is not a condition that's presenting in a 3-year-old. And the presentation, as we said, is going to be a mix of obstruction and bowel ischemia. So the obstruction part is going to lead to bilious vomiting, and this obstruction almost always occurs after the ampulla vater. It's occurring after the biliary tract has inserted itself in the duodenum. So the vomiting is not just going to be food, but it's going to come with bile. And then the twisting part that's leading to obstruction of blood supply leads to the colicky abdominal pain, really differentiating it from things like duodenal atresia and pyloric stenosis. They can have vomiting. Even duodenal atresia can have bilious vomiting, but they're not going to have the same type of abdominal pain. They'll have abdominal pain that's seen with all types of vomiting, but the colicky abdominal pain that really puts kids in a type of pain that's not going to see with just typical vomiting is due to the fact that blood supply is intermittently being cut off from a piece of the bowel. So importantly is not just how you differentiate the diagnosis, but how you're going to manage this disease. So you have to decompress the gut, and you have to give IV fluids, which is similar to other causes of bilious vomiting. Because if they've got obstruction, you want to decompress it to relieve their symptoms and decrease the chance of perforation. And because they have so much vomiting, you need to correct any fluid abnormalities. Recall the possibility of a contraction alkalosis. It can lead to electrolyte problems within the system. You give IV fluids to correct this problem. And then once you've got them stable, you go straight to surgery. But the big concern with volvulus is that these kids are going to decompensate quickly. That colicky abdominal pain that's related to the intermittent cutoff of blood supply can lead to bowel ischemia, bowel necrosis, and then perforation. The moment that's suspected, you start seeing a kid that looks septic, as in they're hypotensive, tachycardic, they're looking ill, they become lethargic, they start throwing a huge fever, that kid's decompensating, and you immediately take them to the OR, and you have to start antibiotics that cover that Enterobacteriaceae, those gut organisms. Intussusception, on the other hand, is when a piece of bowel, typically large bowel or small bowel and large bowel, gets telescoped within itself. It gets shoved in there. It usually occurs on the right side near the ileocecal junction and the ascending colon. So it's when a piece of the ileum gets telescoped inside a piece of the large colon. It happens most often related to a virus. Key this in your memory. So be looking for a history in your vignette of, 2 weeks ago he had a URI or some viral diarrhea that was self-resolving. It went away by itself, and now they're presenting with this severe pain in their abdomen and some vomiting. The presentation is typically a triad of symptoms. It's colicky abdominal pain, which is like what we said in volvulus. It's bilious vomiting, which is like what we said in volvulus and like what's seen in duodenal atresia. But here's a major differentiating factor. Current jelly stool, this sort of dark, bloody stool. This triad is commonly used on Step 2 because, while Step 2 is going to try and trick you, they have to give you enough information to differentiate what's most likely in these situations. And intussusception also most commonly presents within the first year of life. So a major differentiating factor is this current jelly stool. Other keys they might give you is the sausage-like mass. So this one has a palpable mass, like what's seen in pyloric stenosis, but not in volvulus. So volvulus, nothing really palpable. In intussusception, you have the palpableness with the bilious vomiting, which differentiates it from, say, pyloric stenosis, which is just normal vomiting. The first step in management, though, like everything we see with persistent vomiting, you got to get IV fluids on board because you want to correct the possibility of a contractional alkalosis, and they're just in general going to be dehydrated. And then you want to decompress the gut to relieve any terrible symptoms. Now, testing for intussusception is going to start with something that's less invasive because we're in peds. So we're going to start with an ultrasound. You get a kid with colicky abdominal pain, the current jelly stool, bilious vomiting, sausage-like mass or not, it's good to go with an ultrasound because it's easy to do, it's non-invasive, and it can really differentiate between what you see in volvulus or what you might see in intussusception. This is a picture to give you an idea of what the donut sign looks like in intussusception. You've got a piece of bowel right on the inside surrounded by intestinal fat, which is the black, and then you've got more bowel and more intestinal fat, giving you these rings, giving you a clear donut sign, classic of intussusception. But the most diagnostic test, as well as being therapeutic, and this is key, this is the air contrast or barium enema. And it's important to note that this is such a great test in intussusception because it is diagnostic, confirming what you did or did not see on ultrasound, and it's therapeutic because you can use the enema itself to push the bowel out of itself. So think about it this way. If you had to choose between air contrast and barium, which would you choose? I'd choose air contrast because air, in case there's a perforation, just in case, air isn't going to hurt the peritoneum like barium could. Barium will really lead to, more inflated peritoneum and peritonitis. So an air contrast is really your diagnostic therapeutic test of choice. So always, and here's a picture of what a barium enema looks like, and you see the colon lining up, and you can see where it sort of is a sharp cutoff, and that's where the intussusception is. And you just use the enema to push that, and then eventually all your colon will fill up with enema. Look for signs of peritonitis and perforation. That will guide whether you need to go to the OR immediately, because any signs of decompensation, sepsis, perforation, go to the ER and figure the rest out later. But it'll also keep you from doing a barium enema, which will just cause things to get worse. Surgery is going to need to be the management of choice in these more severe situations. And then keep in mind that even with a successful enema, recurrence happens in 10% of the cases. So here's a chart we've put together to cover the 3 most highly tested causes of bilious vomiting. You see bilious vomiting on your test, you got to clue this chart into your brain and then pick out from the vignette the differentiating features of the diagnosis so you know which one of these 3 it's most likely going to be. They all present early, but duodenal atresia definitely occurs the earliest. And that's because it's a physical 100% blockage of the duodenum that is there at birth. Volvulus and intussusception happens sometime within the first year, but for the majority of this kid's first year of life, their colon's completely fine. There's no blockage at all. They breastfeed and then they're absorbing. Duodenal atresia, that blockage is there at birth. So they immediately start to have bilious vomiting within the first day, definitely the first week. And then we got to decide what's the best initial test. Now in the first 2, you're going to glean a lot of information from an abdominal x-ray. But in intussusception, the best initial test is an ultrasound. And a lot of that is because if you have that palpable finding on your physical exam, especially if it's on the right side, an ultrasound will give you a lot of information that an abdominal x-ray will not. Look for the donut sign in the ultrasound of intussusception and the double bubble sign, typically seen in duodenal atresia. The first step in management is IV fluids for all of them, and that's because anytime a kid presents with persistent and or severe vomiting, you have to worry about a contractional alkalosis or other metabolic abnormalities, certainly dehydration, and you got to correct those things. Treatment is surgery, and air enema. So now intussusception could be corrected with surgery, particularly if it's severe perforated intussusception. But the first treatment you're going to go with is the air enema or the barium enema, not surgery. If the kid is stable in intussusception, you start with an air enema. If they're unstable, you go with surgery. But the thing is, anytime a kid's unstable with an abdominal abnormality, you're going to do surgery. So highlighting the main differences, know the time at which they start, the best initial test, and the treatment of choice is really what differentiates these three diagnoses from each other. A Meckel's diverticulum is a thing that the NBME loves to test on step 2, and I think it's because it has a lot of rules with it. It's actually a fairly benign thing, but it has some esoteric facts related only to the Meckel's diverticulum. So the rule of twos, 2% prevalence, meaning 2% of the population has one. It most commonly happens or presents in children under the age of 2 years. It's 2 feet proximal to the ileocecal valve, so it's 2 feet away from the ileocecal valve but into the small intestines. It's 2 inches long. It has 2 types of ectopic tissue, typically gastric and pancreatic, and that's key because of what the diagnostic test of choice is. Males are affected twice as often as females, and only 2% are symptomatic. So, and we know the 2% prevalence from autopsies, which how we got the 2% symptomatic. So just because you have a Meckel's diverticulum doesn't mean you're going to have any symptoms. In fact, you're 98% likely to not have any symptoms of it ever. But the presentation is typically painless bleeding in a boy presenting at 18 months of age. That's how Meckel's really presents itself. And then the bleeding will stop randomly by itself. So key into that fact, painless rectal bleeding. And then it just goes away all by itself. And then it recurs very often. And so the diagnostic test of choice is a technetium 99M scan, because that actually looks for gastric tissue. And when the scan shows up, you'll see a lot of pickup in the gastric mucosa of the stomach, but then you'll see a little hot dot somewhere in the small intestines, and that most likely is going to be a Meckel's diverticulum. Diarrhea in children is an important and very testable topic for step 2 because there's a lot of question stems that start with child presents with diarrhea, and that's whether the question even has anything to do with the diarrhea itself. So when seeing diarrhea on the test and with your patients, there are a few questions you really want to go over to sort of form your differential diagnosis and then what you're going to do. Is this chronic acute? Has it been on for several weeks, months, or has this only been the past 14 days? Because chronic diarrhea is not common in children. People are going to be bringing their kids in if they've been having diarrhea for 3 weeks, and so you're not really going to see chronic diarrhea that often in kids. And then the question is it infectious or not? There are very few chronic infectious diarrheas, particularly in children. But acute infectious diarrhea is probably the most common cause of diarrhea in children. And so knowing these two facets of the diarrhea is going to start to hone your diagnosis in one way or another. And then is it bloody or not? This is an important management question because there are some things you never, ever give to children with bloody diarrhea or anybody with bloody diarrhea. And then if it's non-bloody, then your differential remains fairly wide. And then always, how sick is the child? Because depending on how sick they are will determine what type of hydration they need, whether they need to go to the OR, and what the most likely diagnosis is. Different from many of the previous questions and topics we've covered, diarrhea in children is actually more of a diagnostic challenge on step 2. And that's because the management of diarrhea is often very similar or the same in different cases. And it's going to be some form of oral or IV hydration. Whereas there are many, many causes of diarrhea in kids. And so we're going to focus on how to identify the different types of diarrhea in children. And we're going to largely focus on infectious diarrhea in children. These are largely infectious acute causes because that is the most common cause of diarrhea in children. They largely don't present with chronic non-infectious forms of diarrhea. That's rare in children. So the best way to approach any infectious process, and diarrhea is no different, is to start with the 4 main categories of infections: viral, parasitic, fungal, and bacterial. So starting with the lesser common causes of diarrhea in children, if you're thinking about parasitic diarrhea in kids, the 2 main causes are going to be Giardia and Cryptosporidia. Now, for Giardia, it causes a profuse, foul-smelling diarrhea. Suspect this when the patient has been playing or swimming in a lake, a freestanding body of water, and you're going to treat these kids with metronidazole. And the reason they get a profuse, foul-smelling diarrhea is the infection largely takes place in the small proximal colon and inhibits the uptake and the absorption of fats. So the fat stays in the stool and it causes steatorrhea, or a fatty diarrhea. Cryptosporidia should only really be suspected in the immunocompromised patient. So think in children with congenital HIV infection, a primary immunodeficiency, a leukemia, lymphoma, etc., both of which are sort of unlikely to see on step 2. For the same reason, it's probably unlikely that you'll see fungal causes of diarrhea, but if you do, think of Candida and histoplasma, and the pearl you'll hear in the vignette that should clue you into a fungal cause of diarrhea, probably in an immunocompromised patient, is going to be a stool culture that grows yeast. Again, unlikely. Bacterial causes, on the other hand, are much more common in children than fungal and parasitic, and they have some key features to them to differentiate them from viral diarrhea. And anytime you think bacterial diarrhea, the major clue is going to be very, very sick children and blood. Bloody diarrhea, you think bacterial. So you've got Salmonella, Shigella, C. diff, E. coli, Campylobacter, and Yersinia as the main causes of acute bacterial diarrhea in kids. And a fact that I want you to burn into your memory is that anytime you hear fever, abdominal pain, bloody diarrhea, anytime, any person, never, ever give antidiarrheal agents. They can cause the infection to actually flourish, and that can precipitate toxic megacolon. That is a bad thing. So when your body has the diarrhea and it's bacterial, it's actually trying to flush the organism out. You give antidiarrheals, that allows the bacteria to continue to populate and overpopulate within the colon, causing a super infection. So we want to avoid that. So you never give antidiarrheals. That is never the right answer. So Shigella, remember, it's most often in the setting of like a daycare or a school or any setting where young children are clustered together. And C. diff is classically associated with recent antibiotic usage. Campylobacter is probably the most common cause of bacterial diarrhea in this country, and it's linked with undercooked chicken. E. coli, not such a common cause of diarrhea in the United States, but suspect E. coli and the traveling patient as a cause of traveler's diarrhea, and any immigrant. So, and then it also has an important association with tardy vegetables or undercooked beef and hemolytic uremic syndrome. That's something that's mentioned a lot on the STEP exams as well. But enough of those 3 types of infectious diarrhea. We should now focus on the most common, and therefore our purposes, the most important form of infectious diarrhea in children, and that's viral. So to cover the most common cause of infectious diarrhea in children, viral, let's make a chart that's going to cover the 3 main types of diarrhea that we see in children that are caused by viruses: rota, adeno, and small round viruses. So starting with rotavirus, rotavirus is the most common cause of diarrhea in children under the age of 2. It's transmitted via the fecal-oral route. So kids under the age of 2 are really going to get rotavirus. Think about it, because they're walking around on their hands and knees. They're putting their hands everywhere, and there's poo everywhere. So then they stick their hands in their mouth, they stick their toys in their mouth. The world is not generally that clean of a place. And so if you're walking around on your hands and knees all the time and then putting every object you can get your hands on in your mouth, you're bound to get some rotavirus infection eventually. Now, this typically peaks in the winter time. So be on the lookout for, young 18-month-old boy presents in December or in the winter time with a watery diarrhea. Now, the symptoms are classic of what a viral diarrhea is, and that is it's got vomiting and it's got a fever. It's an infection. It's going to cause a fever. It's got a watery, non-bloody diarrhea. Capitalize that N-O, no blood. And it's a self-limited illness that lasts less than a week. So they might present within the 4th day, they might present at the 6th day, but the truth is it's going to start getting better after the 3rd or 4th day, and it should be gone by the end of the week. Typically, the family will report a recent history of URI, upper respiratory viral-like syndromes. It has a prodrome, so they get the infection, they start their body starts to react to it a little bit, they get a little sniffles, and then the viral prodrome starts to go away, boom, they get hit with this non-bloody diarrhea. The major worry in this case is actually hydration. So the mainstay of the treatment is not treating the infection itself because it's self-limited, but get the kid on oral or IV hydration depending on what they can deal with. If the kid can take fluids without throwing them up, then you give oral. Because try not to stick them with a needle if you don't have to. Remember, pediatrics always go less invasive. And then another key feature of rotavirus, which is not true of the other two, is that there is a vaccine for it. Historically, 10 years ago, there was a rotavirus vaccine that was associated with an increased risk of intussusception. That is no longer true. There is a new rotavirus vaccine that is not associated with the increased risk of intussusception. So that's an old fact that isn't going to be the case anymore. So adenoviruses, moving on to the next one, is probably the second most important cause of diarrhea. It's the second most common. And it tends to be endemic, and what we mean by that is that it occurs year-round, but it's often associated with warm weather. And the reason and the important of knowing that it's associated with warm weather and the fact that it's endemic is that it's not that adenovirus occurs less often in the winter, but its prevalence is eclipsed by the increased amount of rotavirus. So the same number of adenoviruses are taking place in December as they are in June, but the peak of rotavirus infections in the winter makes it look like adenovirus is occurring less often. And then as rotavirus goes away, as the winter ends, adenoviruses emerge as the more common cause of viral diarrhea in children. Some main features, so it's year-round, its main features are very similar to other viral diarrheas. They're going to have a fever, it's an infection. They're going to be throwing up, it's a GI infection. Still, classic viral diarrhea, no blood. Main difference, though, is that it occurs for more than a week. It's not chronic, this is still acute, this is acute diarrhea, but it lasts longer than a week. So if they present on day 8, day 9, they still haven't gotten better, you start thinking this is more of an adenovirus. And there's still a viral prodrome, so look for a history of recent URI symptoms, recent viral syndromes presenting, with a diarrhea for a little bit longer than a week. You're going to think adenovirus, especially if it's in the summer, because adenoviruses can be in pools. Kids are going to be swimming around in pools, and they're all sharing viruses during the summer as they all cluster together to party, and you have little adenovirus spreads. Now, small round viruses, the phrase small round virus might be new to you because I think recently they've used the term Norwalk to sort of represent the whole class, but Norwalk is just one type of small round virus. Now, these tend to be epidemic viruses. The classic vignette will mention that a sort of large group of people on a cruise liner or somewhere where they're all clustered together will come down with an explosive diarrhea that has a lot of cramping and pain. And the cramping and the pain is due to the fast movements of the GI tract that happen rapidly and powerfully to project the fecal matter out of the system, causing the explosive diarrhea. Fortunately, it's short-lived. It only lasts 1 to 2 days. So think of sort of a cruise liner ship that has the explosive outbreak of diarrhea ruining everyone's vacation, but it'll be over within 2 days, and the mainstay is still going to be hydration. So looking at this chart, pick up the key things that will differentiate one viral cause from another. For all 3 viral diarrheas, there are not going to be any blood or leukocytes in the stool. The mainstay of treatment is going to be hydration in one form or another. So you have to key into your memory that regardless of the diagnostic challenges, if they do, cue you up to answer what's the best next step in management, you should always focus on what are they presenting with, they might be hypotensive because they're dehydrated. Even if they're febrile, Tylenol is not the answer. even if they have blood in their stool, getting antibiotics on board first isn't the answer. You still need to hydrate them because they've been losing fluid and electrolytes. You do put antibiotics on board if you suspect bacterial. You can put them on empiric antibiotics and then send the stool for culture. But you don't wait for the culture to come back before you put them on antibiotics, particularly with a suspected bacterial infection. And no matter what, you never, ever use antidiarrheal meds in a patient that you suspect to have bacterial infection. For the reasons we said, you worry about, disseminated infection, worsening infection, toxic microcolon. So that ends our lecture on gastroenterology part 2 as part of our step 2 high-yield review of pediatrics. We covered volvulus and intussusception and how to differentiate that from other causes of bilious vomiting. Then we moved on to Michel's diverticulum and the rule of twos and finished with diarrhea and viral gastroenteritis.